Okay, guys. Attendance quiz for today is poop, capital P with an exclamation point. Dr. Marks thought she was being funny, and she was. Okay, my other question for you guys while you guys are doing this. I made my post-lecture assessment. I didn't know what time they usually are due. I just said before the next class period. Do you guys usually get longer than that? Okay, I will change it right now while I'm thinking about it. To, what is it, the 4th? At the 11:29 a.m.? Thank you for your help on that. I'm sure Dr. Mark sent me an email and I just did not want to dig it up, so you saved me some time. Okay, I know you guys had an exam today. I'm sorry. I blame Dr. Ellington wholeheartedly. We're going to talk about the therapeutics of constipation, diarrhea, and IBS. Listen, a lot of this is going to be reviewed, whether it be from Dr. Mago's class or lecture recordings, or whenever I talk to you guys about constipation and diarrhea in OTC. So hopefully we can move through it fast. Please do not throw fruit at me. I know that there's 84 slides. I tried to cut it down. I will try to make sure that I hit the key points for you guys, really focus on the highlighted things, and we'll try to get through this together. It's just a lot of drugs. Things are color-coded. We'll talk about constipation in pink first, diarrhea in blue, and then IBS. You can see here are the objectives. Let me go ahead and set my timer here. So I will tell you guys, constipation and diarrhea take the longest amount of time, with constipation taking even the longest amount of time, just because there's so many drugs, but we will get it through it all. IBS is a lot of repeat of constipation and diarrhea as well. FYI means that things on that slide are not testable. No dosing is required. You will get either generic or brand. This is getting you guys ready for the NAPLEX. You guys will also see that my questions are usually case-based. And I went ahead and the post-quiz is a lot of my old exam questions with just the demographics changed. So you guys can see exactly how I test. Okay? Let's see here. Exam questions should be based off the objectives. If they're not, come fight me. Find me and I really will give you guys back points, I promise. And there is a study guide posted, and a couple charts to help you guys review. Some things to kind of keep in mind, or some things to help you guys stay organized. Again, FYI means not testable material. Avoid hepatic dysfunction is the SAD liver here. Avoid renal dysfunction is the SAD kidney. There are certain drugs in this that are only approved in women. So that's why we have the female sign. And that would be in sex assigned at birth women. Not used in pregnancy is the no prego. And then little kiddos, no little kiddos is not for children. So let's talk about constipation. Overall, constipation is the difficult or infrequent passing of stools. Usually defined as having less than 3 stools a week. It actually does depend on a patient's normal. There are some patients that may say I only usually have a bowel movement once or twice a week. And so once they get to once every other week, that's whenever they start saying that they have problems. And there's some patients who have a bowel movement every day, and maybe having one every other day might be causing some issues. Usually it's based on patient reports, as that's what the big thing is here. Complaining of straining, lumpy heart stools, pushing for more than 10 minutes, requiring digital evacuation, meaning that you have to use your finger to try to get a stool out. This happens a lot in the hospital. And the sense of incomplete evacuation. This is called tinnitus. Not something you guys are required to know, but you guys will hear about it a lot whenever we talk about IBD in your 3rd year. primary is also known as idiopathic versus there are things that can cause secondary constipation. I do want you guys to be able to recognize things that cause secondary constipation so we can make sure that we are controlling those secondary diseases or those secondary causes before we start giving stool softeners willy-nilly. There is a little bit there about the difference between IBS-C, so IBS with constipation versus idiopathic chronic constipation. You guys are not going to be diagnosticians. I'm not going to expect you guys to be able to recognize the two. I just want to make sure you guys knew what the difference was. So let's talk about our approach to therapy. Start out with diagnosis of constipation. Evaluate the patient's medical history and current medications to make sure that we are controlling for those secondary causes. Am I talking too fast? I drank a lot of coffee this morning. We're feeling good? Okay. And then we start thinking to ourselves, is this opioid-induced or non-opioid-induced? The reason for this is you'll see that for non-opioid-induced, we will use a lot more fiber versus for opioid-induced, we won't use as much fiber. And we'll kind of talk about that as we split it up. But let's just focus on this first little part here, the evaluating the patient's history and current medications. There are a lot of things that can cause constipation. So, of course, we have our two friends, IBS and IBD at the top here. Just so you guys know, IBS is irritable bowel syndrome. IBD is inflammatory bowel disease. You guys may not be familiar with what the difference between those two are. So, IBS is a syndrome. It's a bunch of symptoms that kind of go together and make a disease state or a syndrome. So it's usually associated with infrequent passage of stools or stool changes along with abdominal pain. Versus IBD is an inflammatory disorder that's usually associated with an autoimmune disease, and you have to take medications for it specifically. And it's usually a much more severe disease state associated with like fevers, weight loss, and again, it usually requires continuous treatment. So the big thing here is IBS is probably not as severe of a disease state as IBD, and even though they have a very similar name, you probably can start dividing the two. It's so funny because I'm not going to put Dr. Mago on blast, but I did see that he accidentally called it IBD in his quiz for you guys. It just made me giggle. Now, some other GI disorders that can cause secondary constipation. You have things like Hirschsprunger's disease, which is actually in infants, causing a malrotation of the intestines, hernias and hemorrhoids. Those also can be secondary to constipation in itself too. Heart failure is a secondary cause of constipation. Probably the ones that we see the most are those endocrine and metabolic, especially when we talk about uncontrolled diabetes causing gastroparesis. So all those nerves in your gastrointestinal system, whenever you have diabetes, will stop working quite as well, and things won't push the same way, and that's what causes gastroparesis. And then hypothyroidism is another secondary cause, mostly again due to some gastroparesis. Big thing I want you guys to do here is to be able to identify these things if I gave you a patient case. Pregnancy is amongst the #1 cause of constipation, especially in younger women. Neurogenic spinal cord injuries and things like that, those typically do need a digital disimpactment and will be on long-term medications for that. And then finally, psychogenic. Oftentimes, if you do work in a psych ward, you will have certain patients that have delusions related to their gastrointestinal system. So, for example, I've had patients before who think that spiders are going to crawl out of the toilet if they defecate, and have different delusions related to defecation. So that can occur. We did have a patient that had a horrible spherical ulcer for that reason. It was a very sad case. So, you guys, sorry, my dad is at MD Anderson today. He has prostate cancer, and so they're taking care of him, so I'm just getting messages from my mom. So I might check my phone a few times. But what are some common medications that cause constipation? You guys are almost full drug experts. You're halfway through pharmacy school. Give me some drugs. Opioids. Ugh. Did somebody use the test to take the test? Okay, what else? Calcium. Somebody's getting ready for their PUD and GERD lecture. What else? Yeah, sometimes if you overuse laxatives, that can also cause secondary constipation, specifically like senna, and we'll talk about that a little bit. What else? Drugs with anticholinergic effects? Hey, that is perfect. That's why we say, you know, it's the can't see, can't pee, can't spit, can't defecate. Those are all really good answers. So we do have our analgesics such as opioids, anticholinergic drugs, and I listed some of those here. TCA antidepressants would be something like amitriptyline or nortriptyline. And you guys can delete out the box on the slides if you guys want to be able to see this. I know some of you guys typically use PDFs. Non-calcium channel, non-DHP calcium channel blockers. So that would be verapamil or diltiazem, with verapamil being a little bit higher than diltiazem. Clonidine, diuretic just because it decreases your fluid load. Iron preparations, calcium and aluminum-containing antacids, and then antidiarrheals. So that would be like overuse of loperamide, for example. Did everybody get their picture that they needed? I was trying to make sure I photobombed as many as possible. Okay. Big thing here is that you guys would be expected to be able to find the drugs that would cause this. So does anybody need any clarifications about any drugs that would be in any of these classes? I know you guys haven't had a lot of therapeutics, so I would probably tell you if it was something that like is not already on the list here. As we are collecting on a patient, you do want to ask them some questions, including like what their bowel habits are. So again, what's your normal versus how many times are you currently going? Their medical history, past medical history, and medications to make sure we eliminate those secondary causes. And in some cases, you may do a physical exam, although typically I do try to keep my hands out of people's butts. Asking about rectal exams and abdominal pans, especially from our multidisciplinary team, may be needed. There are some symptoms that are more alarm symptoms that may make us think that the patient might have something that's a little bit more nefarious, such as colorectal cancer or IBD. So that can include things like bleeding, the change in your caliber of stools. That's where you would have what's called pencil thin stools, where it's obvious that the stools are trying to pass by some kind of mass and then they come out always pencil thin. Blood in the stools, once again, weight loss, anemia, a family history of colorectal cancer, fevers, or ongoing nausea and vomiting. Specific things about this ongoing nausea and vomiting may make you think that the patient has something like a small bowel obstruction. You guys would not have to be able to identify like which one of these might be causing which things. Big thing here is just to know these so that you know when to refer. That you're not giving people fiber whenever they actually have a colorectal cancer. So let's look at this patient case. SO is a 65-year-old female who comes to your pharmacy counter asking for some help with picking out medications used for constipation. She usually goes about 1 time per day, but recently her stools have been becoming less frequent, 2 times a week. She has a past medical history significant for chronic kidney disease, CKD stage 4, atrial fibrillation, gout, and diabetes with macrovascular complications. This could include gastroparesis. She's currently on the following medications. I know, I just thought it'd be fun. So, what I want you guys to do is look through those disease states, look through those medications, and tell me which ones might be causing her to have some constipation. Okay, this is what we'll do. We'll go through all the disease states, and you guys can tell me whether you think it might be contributing or it's not contributing. If you think it's contributing, raise your hand. Okay? CKD stage 4, contributing? It can, but at the same time, it wasn't on our list, so it's totally fine. Okay, let's do another one. Atrial fibrillation. Not really. Not quite heart failure yet. Gout. The diabetes with microvascular complication or diabetic gastroparesis. Okay. And I will say for an exam, I'd be a lot more specific here. I was just trying to create some conversation. Okay, let's look at the medication list. So probably out of this list, the big one you guys should have been able to identify is the diabetes with microvascular complications or gastroparesis. Okay, she's currently taking the following medications. Do you guys think the vitamin D, cholecalciferol? No. How about calcium carbonate? Yeah. I love a strong yes. Ferrous sulfate. Perfect. Nephrovite. No, just C and B vitamins. Verapamil. Yeah. Magnesium oxide. That's diarrhea. That's right. That's a funny thing to get excited about. That's diarrhea. Yeah. Colchicine. Digoxin. Metformin. I will note, just so you guys have answers for the next one, all the ones over here are ones that cause diarrhea. So you guys can have those preloaded for later. Okay, so we went through a lot of the secondary causes. We're going to really get into the nitty-gritty of treatment. How are we feeling, team? Feeling good? Sweet. Okay. Relief of symptoms, managing underlying causes and secondary disorders, and minimizing adverse effects of treatment are our main goals of therapy here. And again, that makes sense. We really just want to relieve the constipation, make sure that we're controlling anything that could be causing the constipation. And then these drugs can have side effects, so we're just picking the right drug for the right patient. So let's go back to our approach to therapy. We're really going to go down this non-opioid path first. And then we can kind of talk about the opioid-induced second, because we do have some specific drugs for that as well. So if we have non-opioid-induced, we make sure that we don't have any alarm symptoms, history of physical use, possible secondary causes, including medication. Obviously, we have some secondary causes. Let's try to control those or stop the medications if possible. If you still have no relief, that's whenever we can start doing therapy. So, just so you guys know, this is here. So now we're down to this. Non-pharm therapy is kind of our next one. We're going to talk about non-pharm therapy. Non-pharm therapy revolves around the 3 F's. Fluid, fiber, and fitness. So we'll talk about those, and then we'll start getting into actual therapies. Okay? So, again, fiber is the backbone of constipation treatment, especially in those with non-opioid-induced constipation. You want to try to get to 28 grams for women and 38 grams for men. You can either do this via diet, which is preferred, or adding bulk-forming laxatives. So, this is the weird thing. Bulk-forming laxatives are things like Metamucil. So they are drugs. They're FDA approved, but they're also non-pharmacological therapy. So they kind of blend in here, okay? But we'll talk about both. But the big thing is you want to try to get it in your diet first before you add supplements. The next thing is you want to make sure you're doing fluid. So you want about 1.5 to 2 liters with a high fiber diet. Big reason here is because if you don't drink fluids with fiber, it all gets stuck up in your intestines, and it's not very helpful. And then finally, regular exercise. So once again, fiber, fluids, and fitness. Walking around, moving around actually does help with bowel movements. I see it all the time in the hospital. Patients may have had 3 or 4 days without a bowel movement. As soon as they get up and walk, it happens. Now, there are some fluids you might want to avoid, such as fried fatty foods, red meat, or large amounts of milk or cheese. So maybe hold off on the funnel cakes whenever you're constipated. Now, the milk and cheese is kind of a mixed bag. If you are lactose intolerant, it can obviously cause a bowel movement. But if you are not lactose intolerant, large amounts of milk or cheese can be quite constipating. So for the patients that are on the very, very extreme end of trying to take care of things, like if they have a small bowel obstruction or a malignancy, we might do surgery. We might put in a stimulator for biofeedback or a sacral nerve stimulator, or even do abdominal massage therapy to try to get the constipation out. This mostly is for patients that are really on that extreme end, such as if they have a small bowel obstruction. For most of our patients, we're really going to focus around this non-pharm therapy. I will actually allow you guys to put an FYI on this page. Write it big and strong. So, as I mentioned before, we got a lot of drugs to talk about today for constipation. Diarrhea, we only have 2 drug classes. So, starting at the top here, we have our bulk-forming laxatives. You will see I put these stars around the things that are actually top 300 drugs. Bolded the ones that are prescription only, because those are kind of your new ones, because we talked about a lot of these with non-prescription products. And they should be labeled OTC or RX appropriately. Let's see if there's anything else I need to get you guys accustomed to based on this slide. So stars are your top 300 drugs, and again, the RXs are bolded. Okay? Now, you guys can look at the objectives. I'm not going to be which one's a prescription drug, which one's an OTC drug. I only get 8 questions, guys. I'm going to do something more fun than that. But the big thing here is just for whenever you guys are practicing to know where to find things. So we're going to start with bulk-forming laxatives. These are fiber supplements, is what else you can also call these. We're only going to focus on the fiber supplements that are FDA-approved fiber supplements. Yes, there are fiber supplements that you can get from over the counter as supplements or dietary supplements, but we're just going to focus on the ones that are FDA-approved. Overall, these have very few adverse effects. Abdominal bloating, distension, and flatulence are the big ones. You do want to make sure everybody drinks 8 ounces of water with these and drinks plenty of fluids. If you don't, it can cause a choking or bowel obstruction. If you have issues swallowing, these are contraindicated. And you may want to educate your patients on signs and symptoms of bowel obstructions. So change in bowel absence lasting greater than 2 weeks. And signs and symptoms of esophageal obstruction, because that can occur, especially if you don't drink enough fluids. We have 3 major ones that we're going to talk about. Methylcellulose, or 4 major ones. Methylcellulose, polycarbonyl, psyllium, and wheat dextrin. Big things to keep in mind here. So, starting with methylcellulose, usually very well tolerated, only if you have phenylketonuria that you really need to avoid it. So, the one that you would prefer if the patient does have this is polycarbonyl. So Fibercon or polycarbonyl, it does have a calcium cation. So if you have any drugs that may chelate to it, you do want to make sure that you administer 2 hours before or after any other medications. And then our final 2 down here, you have your risk of allergic reactions because they do have wheat products in them. So just to kind of think to ourselves, when do we use each one? So if you do have a patient with a wheat allergy, try to use one of the top 2. If the patient has phenylalkylaria, you want to make sure that you use polycarbonate. And then one little fun fact about psyllium, it may decrease your blood cholesterol. It's been shown to do that, and blood glucose in a few studies. This is why cereals such as Cheerios have the thing about how they're heart healthy. It's because this has been shown to decrease your blood cholesterol and blood glucoses. I do have some friends that swear and are like part of a cult related to psyllium. They love their Metamucil. They're like, my life has changed based off of Metamucil. I give it to all my friends. I've also had friends who are like, no, that is awful. It hurts my stomach. Why would you ever do that? It's one of those brewery conversations that you get into sometimes. Like, oh, okay. So, even though those are products that are OTC, approved by the FDA, they actually still fall into that non-farm category. So what you're going to do is, first, non-farm, that includes increasing fluid intake, dietary modifications to increase fiber, and start a fiber supplement. Okay? How are we feeling, team? Everybody still on the same page? Is anybody on Amazon as a page? Okay. Let's move on, and we're going to talk about what our next options are. So really, we can divide into two different ways. If a patient needs immediate relief, like they're like, I have not gone in 3 or 4 days, I am miserable, please help me. I don't know if anybody has watched the recent episode of Real Housewives of OC. Shannon really needed an enema. But if you need immediate relief, a suppository or enema is the way to go. I know, you guys don't watch real TV, it's fine. Just leave it to me and the other old ladies. And if they don't need immediate relief, then we can add an osmotic laxative. So let's talk about osmotic laxatives next. There are multiple different drugs that fall into this class. So probably the most frequently used one is polyethylene glycol. It's also known as PEG. You can see it has a star because it is like the #1 drug, and that's why it's in your top 300. And you can see here that it overall doesn't have a lot of side effects. Most of these laxatives are supposed to be avoided in patients with small bowel obstruction, so you're going to see that across the board. But the biggest thing here is electrolyte disturbances just from excessive GI losses. But again, overall, it's very well tolerated. You do have a product that is a prescription product called Go Lightly, or one of my students the other day called it Golitly, or Golitly, but Go Lightly. These are the big jugs that you probably see in your pharmacies that are full of PEG. So what we use in Miralax, or the kind of the over-the-counter PEG, is only 17 grams. Go Lightly, now I'm going to say it that way, is 238 milligrams. You usually do give it with electrolytes for GI procedures, just so that you don't have the electrolyte disturbances. And again, that's part of bowel prep, just to make sure that we clean out all the stool from the colon prior to either operations or colonoscopies. Lactulose is kind of our next one here. And I'm sorry, my original slides had a little bit darker so you could see easier. So hopefully on your guys' screens, you guys can see a little easier where each of these split. But so lactulose is our next one. Biggest side effects, once again, is electrolyte imbalances. Lactulose and sorbitol are both really big complex sugars that our body can't break down. But one of the side effects of them, because they do usually get put in syrups, are that they do cause hyperglycemia for diabetic patients. Once again, for both of these, their biggest ADR is electrolyte imbalances. And there are some additional considerations for lactulose. So it can enhance the anticoagulant effect of warfarin. And it does get used in hepatic encephalopathy. And you guys will learn about that a little bit later, but that's just a little teaser for you. Again, really focus on the highlighted things and knowing where these drugs fall into therapy and when you're going to use certain drugs versus when you don't use certain drugs. So, for example, you do want to avoid sorbitol solutions in patients with renal dysfunction because it can cause worsening electrolyte imbalances. And for your magnesium and phosphate-containing products, you want to avoid those in patients with renal dysfunction. So magnesium products in renal dysfunction causes increased magnesium. Oh, big surprise. And for the sodium phosphates, it is that acute phosphate neuropathy that you worry about, especially in patients with cardiovascular disease or chronic kidney disease. This is the reason why sodium phosphate is contraindicated in patients with heart failure. And then finally, you have glycerin suppositories. They are OTC. They're typically used in children needing immediate relief. It's considered the more gentle suppository. Overall, it doesn't act quite as quickly as some of the other suppositories we'll talk about with stimulant laxatives. And that's why it's not used quite as frequently in adults. But for children, it's pretty easy to use. So it's considered like the more gentle suppository. Okay. Highlights on these slides. Know the kidney dysfunction ones. Really know that PEG is probably the most commonly used one and best tolerated one. Glycerin suppositories are usually used for children. I'll give you guys a minute to write all that down. Or not. Just soak it in. Okay. So, for opioid-induced and non-opioid-induced constipation, I went ahead and highlighted where each of these drugs are in this, where PEG is in each of these. So, are osmotic laxatives. Okay? So, the next thing we're going to talk about are really talking about one of the suppositories and then stimulant laxatives, which are kind of your second-line therapies. So, what we talked about overall is that the long-term use of these agents is very controversial. You should try to use it for less than 2 weeks because it can cause what's called a cathartic colon. So, what was mentioned before about overusing of laxatives causing constipation, this is the one, or these are the ones. So, you have Senna tablets and bisacodyl as the two major therapies in this class. Senna is actually a plant-derived compound. Bisacodyl is synthetic. Bisacodyl comes in tablets and a suppository. The suppository is very fast-acting, and it causes pretty much immediate relief. The biggest concern is that it can cause some irritation of the rectum, and that's what proctitis is. So that's really just kind of a local irritation situation. Overall, both of these the bisacodyl, the reason you're supposed to avoid an appendicitis is because really having overstimulation during appendicitis increases your risk for perforation. So that's why that's in there. And then for Senna, the biggest thing to kind of keep in mind is long-term use of Senna has been shown to cause this melones coli, which is really just browning of the colon. We're not sure if it actually is associated with any worse outcomes quite yet, but it does cause this browning of the colon that you'll see on colonoscopies. Just to remind you guys, bisacodyl and Senna are both top 300 drugs. Probably whenever I talk about like which one I use the most, I use Senna the most because it does come in the combination pill with Docusate. So let's go back to our little algorithm here. You can see that for opioid-induced constipation, they really talk about using Senna or stimulant laxatives with a stool softener. And since it comes in that combination product, it's very easy to give for my opioid-induced constipation patients. On the other side here, you probably could pick one or the other. I do work in trauma and acute care surgery. Almost all my patients are on opioids, so that's the reason why I use that product a lot more. And again, we can see here where all these agents fall into this algorithm. So now we get kind of into some of the weirder stuff. We were in kind of the normal parts of the algorithm. Now we're going to get to kind of the outer sides of the algorithm. First, let's talk about stool softeners. Really, there's only one stool softener, and it comes in two different salt forms, sodium and calcium, and that's docusate. Sodium is much more frequently used. There's not a real difference between the two of them. They're both equally potent. Big things to know about stool softeners. They are mush with no push. They are not laxatives. They just soften your stools. They will not treat your constipation. They may help prevent your constipation. So like if you take something like a iron tablet, you can give it with iron tablets to help prevent constipation. But once you're in constipation, it doesn't do much. That being said, it is a very well-tolerated drug. I always jokingly say, stopping somebody's docusate is never a hill I'm going to die on. You like your docusate? Go have fun. Docusate in the liquid form is kind of irritating to people's throats, so I do try to switch those over as quickly as possible, especially in the hospital, to the PO like tablet form. That's it's just better tolerated. And you might want to keep that in mind if you are trying to give it to somebody over the counter, that this can really irritate your throat. It does have one small drug-drug interaction with mineral oil. So we'll talk about that here in just a minute. You can see here that it really only is used in our little algorithm here as an adjunct therapy to stimulant laxatives or osmotic laxatives in patients with opioid-induced constipation. Again, mush with no push. We always want to make sure that if we are giving it, we're giving some push with it, whether it be PEG or Senna or a stimulant laxative. Okay. Our next agent is mineral oil. Don't freaking use it, mineral oil. It's not well tolerated. Literally the only time I've ever given mineral oil to somebody is because it will kill the maggots on their leg because it suffocated them because they had a wound that was so bad it had maggots in them. Just don't give mineral oil. Reasons why. One, it can cause aspiration in old people. It causes leakage. It interacts with other fat-soluble things, including docusate. Again, just don't do it. Easy slide. Mineral oil will never be the answer on the test. Okay. Let's get to the costly drugs. All the ones we've talked about before, usually well-tolerated, inexpensive medications that you can get over the counter. Now we're going to talk about some drugs that are a little bit more expensive, and these are usually further down in the treatment algorithm for that reason. So we have lubiprostone, or also known as Amitiza. It is a calcium chloride channel activator, and I'm sure that Dr. Mago already told you a little bit about that mechanism of action. Big things to keep in mind here, it's not super well tolerated. It is associated with dyspnea, edema, hypotension, and syncope. So you do want to make sure that you do tell your patient about those. Usually those are kind of transient and only occur over the first couple weeks of therapy, and patients usually do tolerate them in the end, but it is something to make sure your patients are aware of. Linaclotide is a little bit better tolerated compared to Amitiza. So if you have a patient that doesn't tolerate Amitiza, they may tolerate linaclotide. It has a different mechanism of action. It does have a box warning for pediatrics because of the risk for dehydration. I will tell you guys, the Naplex loves a box warning. They love testing about box warnings. Just no box warnings. That's why I've highlighted it. It's not something that comes up in my everyday, but again, we try not to kill people. The ADRs are much better tolerated headache and GI side effects. Plineclotide is like linaclotide, thus the names being similar. They have a similar mechanism of action. Really, all the side effects here are, once again, primarily GI in nature. It is also not indicated in children. One other thing you guys can maybe note about these drugs, linaclotide does have to stay in its original container. That's mostly for counseling points. I will give you guys a break in 5 minutes. No, it's okay. I just didn't want you to make you think that I wasn't going to give you guys a break. That made me sound like a jerk. I'm sorry. I usually try to sound like a jerk on purpose. Okay, where do these drugs fall? So lubiprostone is actually indicated in opioid-induced constipation. The other drugs are all indicated for like constipation associated like chronic idiopathic constipation in that third line therapy. So you'll see here that that's why lubiprostone only falls over here versus all the other drugs are listed here. Which brings us to our last couple therapies. So our serotonin receptor agonist. Okay, we have Motegrity and Zelnorm. Big things to keep in mind here. We are messing with serotonin. Usually when you mess with serotonin, it usually does something to your brain. So this has an increased risk for suicidal ideation. And it's pretty easy to remember because, again, we're messing with serotonin. So, Motegrity, biggest side effect is really that it can cause you to maybe have some dizziness, drowsiness, ataxia, things like that, some CNS side effects. So you do want to make sure you don't drive or operate machinery until you know how it's going to affect you. For Tegosterod or Zelnorm, here's the thing. It was associated, so Zelnorm used to be everywhere. It was found to be associated with increased risk for cardiovascular events. So for that reason, you cannot give it to patients that have any cardiovascular risk factors. Guess who have cardiovascular risk factors? All males. So it's only indicated for females, and they have to be less than 65 years old. It also has an associated ischemic colitis risk. And you have to get an intended use disclaimer to use it. This is way down on the therapies. However, for the Naplex, I have to teach you about it. Any questions about these drugs before we talk about the Pamoras? Okay. Pamoras. This is peripheral acting mu-opioid receptor antagonist, Pamora. So how these drugs work. Opioid receptors are located throughout your entire body. In the CNS system, that's what really helps with things like pain management. Also that feeling of euphoria that occurs. Also respiratory depression that occurs. They're in your skin. That's why whenever you go in withdrawal, you can have pinprickle goosebumps. And I'll kind of talk to you guys a little bit about that whenever I talk about pain management therapy. They're also in your GI system. And in your GI system, agonism, or attaching to the mu-opioid receptor, causes a slowdown of your gut function. Okay? Thus why opioids cause constipation. What mu-opioid receptor antagonists do, so these peripherally acting ones, they go into your system and they just attack the GI mu-opioid receptors. and they cause antagonism. So they hold onto that receptor tight enough that all of the GI side effects associated with opioids don't happen because the opioid can't get to that receptor. They all have NAL in them except for Imovig, Imovapan, or Interig. So they have nalmefene, methyl naltrexone, and naloxegol. They all have their place in therapy. Both nalmefene and naloxegol shouldn't be used in patients with renal dysfunction. Naloxegol is associated with CYP enzyme, so you have to do dose adjustments for 3A4 drugs. One nice thing about Relistor, or methyl naltrexone, it does have a sub-Q version, so you can actually give it as an injection, which is very nice when people have something that's causing them not to be able to use their GI tract. So it usually is on hospital formularies for that reason. Now, I talked primarily about the first three because Interig, or Imovapan, was only really indicated for patients to prevent post-op ileuses. What happened is it caused more myocardial infections. So we don't really use it anymore. Every once in a while I have a doctor be like, why don't we use Interig anymore? And I'm like, because people died. So it's another drug that you probably won't use, but it is good to know that it does have this box warning associated with it. Because once again, Naplex loves box warnings. Again, Pamoras are only really used for opioid-induced constipation because they work through the opioid receptor. So let's look back through this really quickly. So you have non-opioid-induced constipation versus opioid-induced constipation. In opioid-induced constipation, we want to try to taper or withdraw the opioids if possible. If that doesn't work, so once again, we're leaving those secondary causes. You'll either do a stimulant laxative or an osmotic laxative with or without a stool softener. Once again, that's why I talk about that Synodocusate combination pill, because that does make it very easy for us. Next, we have our and then if that doesn't work, then we use Pamoras or lubiprostone. On the opioid-induced constipation, the biggest difference here is really the use of fiber in non-pharm therapy. Once we treat those secondary causes, we will try to use fiber or add that fiber supplement on top of it. If that doesn't work, osmotic laxatives. If that doesn't work, usually a stimulant laxative, and that's kind of your usual progression. I listed the onset of action for all these drugs just for your guys' information. Let's go ahead and do this case, and then I'll give you guys a little break. CL is a 61-year-old female who presents to your clinic with complaints of constipation for the last several weeks. She has a past medical history significant for hypotension, hypothyroidism, osteoporosis, and GERD. Once ensuring constipation, the secondary cause of CL's constipation is controlled, what is the most appropriate initial choice for CL's constipation? Take a moment, and you guys are all going to yell at me the right answer. We feel it? Okay, what are we going to do for this patient first? We make sure all the secondary causes are taken care of, and then we give not one F, not two Fs, but 3 Fs. So we make sure we give plenty of fluid, fiber, and fitness, i.e. non-pharm therapy. If she says, you know what, I don't like leafy green vegetables, I don't like fiber that much, what can we add on to her diet? Fiber supplements with bulk-forming laxatives. If that doesn't work, our next option is, yes, Miralax or an osmotic laxative. If that doesn't work, stimulant laxatives. If she needs immediate relief, suppository or enema. As they say, what up the butt. Okay. How about we take a 5-minute break? We'll come back strong for diarrhea.